Hi everyone, welcome to Medical Associates Health Check. I am Dr. Christopher Bristow and I am the founder of the Concierge Medical Clinic and specialist physician in internal medicine. And with me today we have our co-host.
Hi, I'm Dr. Laisha Salvaraja. I am the clinical administrator for Medical Associates Hospital.
And today we'll be having our special guest, Dr. Adrian Ramkisoon. He's a specialist urologist and we're going to be talking about prostate disease today. Welcome, Dr. Ramkisoon.
Hi, thank you for having me.
It's
Nice,
a pleasure. So let's get into it. Let's talk about common prostate diseases.
All right. Well, before we start, let's first define what is the prostate.
Oh, that's a great idea.
All right. So the prostate is the size of a walnut. It's located just below the bladder. All right. And so what's the function of the prostate? The prostate is the reason why all of us are here, because 85% of our ejaculate come from the prostate gland. This allows sperm to live. So without the prostate, there will be no reproduction.
Right.
So that's the benefit of the prostate when you're in the childbearing years. However, as we get older, the prostate starts to give some trouble. So the top three problems that the prostate causes as you get older in life is prostate cancer, an enlarged prostate, and infections. Prostate cancer is the most common cancer in Trinidad and Tobago. It accounts for 21% of cancers in Trinidad.
In males.
No. In Trinidad. And when you dissect it further into the male category, it accounts for 42% cancers among men.
That's significant.
Correct. Now, this is scary data.
Yeah.
And this is data that we acquired from the Elizabeth Commoner National Cancer Registry.
Wow.
Now, what's even more scary is that we know that in Trinidad and Tobago, we are a multi-ethnic society.
Yeah.
So there is a clear division between prostate cancer between the Afro-Trinidadian and the Indo-Trinidadian. The incident rates accounts approximately 4-1 between Afro to Indian. And when we flip the figures across for mortality, it's even more, 5-1. So with this kind of data, we know that this cancer is something we should put a keen eye on and be very aggressive in our treatment.
But it's not just in Trinidad and Tobago, though. I think there's a predisposition around the world for prostate cancer towards the African ethnicities, not
Yes,
so?
that is true.
Right.
In the United States, there's a lot of paper, a lot of documented articles where they talk about Afro-Americans having the risk of prostate cancer 3 to 4 times more likely than the average white American.
Okay. So why is that?
Well, 2 things come into play. Genes and the race.
Okay.
All right? Genes, for example, certain genetic markers, certain genes in your DNA may be switched off or get mutations. For example, their prostate cancer could affect the BRCA gene. So patients who have the BRCA2 mutation, which is normally found in breast cancer, you have a 40% likely chance to have it. If you have that mutation, to have prostate cancer.
Okay, so let me ask you a technical question. If you have a mother who had BRCA2 positive breast cancer, is there an increased risk as a child for you to get prostate cancer, a male child?
Yes, it goes up to 40%.
Oh, okay.
So our data, with genetic testing nowadays, we strongly recommend that child, as he hits 30, 35, 40, please get checked out. Very, very important.
So, Doc, what other, besides prostate cancer, there are other diseases of the prostate that men would come to the doctor for. Some of them might come in emergencies, like they just can't pee. Right?
We see
That
that
is
all
a
the
classic.
time.
That is
Yes.
a classic one. You know?
Trinidadians.
Can't
We went to a party, a birthday party, had a couple bubbly, or came home at night, wake up in the morning and just cannot pee. This is a very common condition among all men internationally. It's called BPH, benign prostatic hyperplasia. It just means that the prostate has gotten bigger in size. Think of it this way. The prostate is like an apple, all right? And you put a straw, you stab the prostate with a straw. That straw through the apple, so that straw is your urethra. And the apple now grows and gets bigger and squashes the straw. So therefore, no flow through the straw, you cannot pee. So this is a very common condition. In fact, evidence shows that 50% of men at 50 years old will have some problem peeing, while 60% of men at 60 years old, it goes up to 70% of men at 70 years old, 80% of men at 80 years old. So you can see that there's a direct correlation with as a man gets older, he will have some problems passing urine. For And that is a very, very big problem. And those gentlemen tend to come into the emergency department, they cannot pee.
Yeah.
But when you further elicit a proper history, they will tell you they're waking up in the night to pass urine. They're going to the bathroom very frequently. They're passing very small amounts of urine. All right. They find their stream, instead of hitting the wall, they're watering their toes. All right. So these are the symptoms of an enlarged prostate.
And that water in your toes is because the power of the stream is not as forceful. It's not-
Correct.
it's
So
not
your
about
stream,
the size.
yeah. So once it squashes on the urethra, you see, it's very interesting because we will think that a very, very big prostate will cause compression. For example, the normal size of a prostate is 15 to 20 grams. Good. So you will say, okay, a guy who has a 25-gram prostate should never have any problems, but that's not true. Because he could have a 25 grams, but it's growing inside and squashing the tube.
Right.
And you could now compare this to a guy who has a 100-gram prostate who's walking around Trinidad, bathing in Maracas, and he's peeing really good. He could hit the coconut trees. But you see, his prostate is growing outward, but his passageway is not causing any problems, which is why once you have the symptoms, you have to be evaluated,
Right.
get a proper ultrasound, see the anatomy of the prostate, and get treatment.
Okay. Dr. Ramkison, I have a question for you.
Sure.
We all know size matters, but in the realm of prostate cancer, does it really matter?
Absolutely not.
Really?
Yes.
Okay.
You could get prostate cancer with a very small prostate, and you could get prostate cancer with a very large prostate. So when it comes to prostate cancer, the size of the prostate has nothing to do with it.
What is the benefit of screening for prostate diseases?
Well, it is recommended by the American Urological Association that all men should be screened for prostate cancer.
Okay.
And the reason for this is that prostate cancer is a curable disease. It is one of those cancers, if it's picked up, it can be cured. In fact, we have a number of patients who we have screened at Medical Associates who went on to have surgery with us, and they are completely cured. They are 3, 4, 5, 6, 7, 8, even 10 years out, living their life normal.
I know one caveat they'll usually say is that men very rarely die from prostate cancer.
And that is true.
Yeah.
But we are noticing that in our population, we have to be very careful because with our statistics, 42% of our cancers in men are due to prostate cancer. We have noticed that prostate cancer in Trinidad and Tobago, Jamaica, is more aggressive than the prostate cancer they normally tend to find in the US.
That's interesting. Is there a reason why?
So we actually don't know as yet. We're
Okay.
still trying to figure it out. But we need to do some genomic studies, which will cost a lot of money. But eventually, time will tell us why do we have this higher risk of prostate cancer.
Okay.
And then secondly, we tend to see a lot of more aggressive late-stage prostate cancer in Trinidad because men also have this perception that they don't want to get screened because, they are fearful of the screening tests. They're fearful of the fingers, so they watch some doctors and they
So
see the fingers.
hold on to that thought because we're going to come back after this short break and you're going to tell us all about how we do our screening. So don't go anywhere. We'll be right back.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, number one healthcare for the entire family.
Prostate cancer, if detected early, is a curable disease. A man's risk factors must be identified upon consultation. These include a family history of prostate cancer or any cancers, medications such as 5-alpha reductase inhibitors, which may halve your PSA, or being Afro-Caribbean, and exposure to toxic chemicals. Men with these risk factors should begin screening at the age of 40 years old. Conversely, men without these risk factors should start screening at the age of 45 years old. Over the age of 75 years old, screening should be performed on gentlemen who have a greater than 10-year life expectancy. A prostate biopsy is a technique where the prostate tissue is sampled and sent to the lab for histological analysis. The prostate is numbed using local anesthesia, and then using an ultrasound, the prostate is divided into zones. Tissue is taken from each of the zones and sent for analysis. An MRI can be used to further increase the accuracy of the biopsy. There are two ways to perform it, transrectal or transperineal. Men don't delay, get screened and get checked out.
Welcome back to Medical Associates Health Check. So, Dr. Ramkisoon, before the break, we were talking about screening and examinations. So, talk me through the screening process.
Right. So the American College recommends that screening begins at the age of 50 years old. However, if you have a family history of prostate cancer, that means if your dad, your uncle brothers, anybody had prostate cancer in your family, you should be screened earlier.
Okay.
In addition, if you are known to have the BRCA2 gene, you should definitely be screened earlier. Also, if you have family members who are females who have breast cancer, ovarian or pancreatic cancer, please be screened earlier.
Okay.
So what does screening entail?
Yeah, I want to know. I need
So,
to know.
you know, everybody here, if you ask a man driving a maxi, hey, you're going to get checked for prostate cancer. Nah, doc, me and want nobody push my finger up there.
Okay.
You know, but screening is two parts.
Let me
It's a
ask you
blood
something
test.
before you run there. How big of a factor is, or how big of a deterrent is that?
In the past, it was a big deterrent, but with education gains wisdom.
Okay.
And a lot of our population is being educated, and that's the purpose of our show also.
Right.
So we are given the nuggets, we are given the golden information, so men don't have to be afraid to get checked up, because the exam lasts a few seconds. It's not like somebody going to build a house inside there, you know? So just come. It's two parts. It's the physical examination. It's very quick, and it's the blood test.
Sure.
Once you do that, then your doctor now will tell you where to go. So where do you go? So we all know about PSA, the blood test good. What is the blood test is good? On the range, you will see 0 to 4. That is just the laboratory range. That has nothing to do with it's good. Anybody PSA greater than 3.0 nanograms per mil, in accordance with the NCCN, which is the National Cancer Network guidelines, you should be checked out.
Okay.
Good.
That's interesting.
Yeah. So I mean, a PSA alone is not good enough,
No.
No.
and a rectal exam alone is not good enough.
It's like a marriage, husband and wife. You know, have to go hand
They
in
do the
hand.
both. Yeah. Good. So, doc, you know, there might be a common question as if could you have prostate cancer and an enlarged prostate in the same prostate?
Yes, that is very common. We see it all the time. In fact, majority of men who we diagnose with prostate cancer have an enlarged prostate. And yes, you could, and it all has to do with the origins of where the prostate cancer derives from, the peripheral zone, and the enlargement of the prostate is the transitional zone. So yes, that is a very mythical thing that has been transmitted, but it is the truth. You could have both of them existing in the prostate at the same time.
So, I mean, doc, when let's say we figured out this patient has some kind of prostate disease, and we want to, you know, get them treated. I mean, you know, sometimes general practitioners might hold on to these patients and try different things. And even some trainees, they have a home remedy for everything. What's your take on home remedies, GP treatment, and then coming to a specialist like yourself?
Well, so let's split it up into the two major causes. All right? Prostate cancer and enlarged prostates. Both of them, this is Trinidad and Tobago. We have home remedies for everything. So, prostate cancer, home remedies really don't work.
Good.
What happens, they just delay the onset. And when you present back to your doctor, instead of being at a stage 1 or a stage 2, where you could be offered a chance of a positive cure, you now present at stage 4, where there's cancer riddled throughout your whole body, and you have to be calling the funeral home and making arrangements.
Right.
So, what I strongly recommend, once you have an elevated PSA and things are off, elevated PSA or the examination is off, please see a specialist. Please come see us. Let us take it from there. Let us check you up. What will we do by checking you up? We will offer you to do an MRI. The MRI is like, think of it like this. You have gold on your land, but you don't know, you have 200 acres, you don't know where the gold is. You just can't go digging all over the place. So the MRI, similarly, the land is your prostate. Somewhere inside your prostate, there's something that's causing your PSA to be elevated. So you come, you see us. We will send you for a special MRI called an MP MRI. That MRI will map out the prostate and give us ideas where exactly in your prostate there's some lesion or something that's causing your PSA to be elevated. And then we will do what we call a transperineal prostate biopsies. We do a lot of transperineal. In fact, I do a lot of transperineal prostate biopsies in medical associates.
And you do that on the ultrasound guidance.
Ultrasound guidance. So we combine the MRI images with the ultrasound. We find whatever nodule there is. We take pieces of tissue from there and sample the rest of the prostate, and then we send it to the lab and test. Within 3 to 5 days, we get back results. So within a week turnaround time, you know exactly what your status is, where you're going. And that's for prostate cancer.
So let's talk about that, right? Let's say you have somebody with a positive biopsy for cancer. Where do you go from there?
Right. So the next thing you assess is their life expectancy. If you're a fit, healthy man, we are going to intervene with cure. If you're an older gentleman, very multiple medical problems, you're not going to live past the next 5 to 10 years when we assess things, you may not need anything surgical or you may not need anything radiation. We might manage you just with tablets or injections. But for the younger guys in their 50s, early 60s, and even early 70s, treatment is divided into 3 arms. There's active surveillance, where you're watching the prostate cancer, surveilling the cancer every year. But this should not be the first and foremost, because this is only recommended for very low risk prostate cancers in a few of your cores. So you can't mistake you can't mistake different types of cancers and recommend this. All right? Remember, medicine is personalized. The other options is a surgical treatment. We do in Medical Associates a number of nerve-sparing radical prostatectomies, where we spare the nerves for erections and for continence, take out the prostate, and just like plumbing, take out a check valve and we join the pipe back. So we join back the bladder back to the urethra. Okay, and then the other option for treatment of prostate cancer is radiation. So these are the 3 main treatment options. But as the histology dictates, you get a Gleason score, which looks at the aggressiveness of the tumor. And based on the aggressiveness of the tumor, then we decide which option is best for you.
See, you mentioned aggressiveness of prostate cancer in Trinidad and Tobago and Jamaica. So how does that affect how you treat the patient?
Well, I tell my patients the truth. I tell them this is what we deal with, and this is what how our prostate cancer in our country behaves.
Okay.
And most gentlemen, if you have a heart-to-heart talk with a man, they will simply tell you, Doc, get it out. I want to live.
But Adrian, the management for prostate disease itself, and especially prostate cancer, there's some hormonal component to this, right?
Correct.
So how you navigate telling a man that they might need to lose their testicles as part of a treatment for prostate cancer?
Right. So the hormonal component that Dr. Bristow is speaking to is called androgen deprivation therapy. It can be surgical, where you remove the testicles, or it can be done with medication injectables. A lot of patients know about these injections, and we generally give this to gentlemen who have passed a certain stage of prostate cancer. So these are the guys where their prostate cancer has spread throughout their body. So in those cases, you want to pull back the testosterone. You see, just like a car needs gas to drive, prostate cancer cells need testosterone to multiply.
Right.
So if you pull back the testosterone, you are going to definitely be able to treat this cancer. So we do a lot of androgen deprivation therapy. But coming back to the point where you have to tell a gentleman he may have to lose it, that is fought with a lot of ideologies and a lot of our population, what we think was handed on through the generation. And once you have an honest discussion with them and you work out the cost benefit regarding the surgical option versus multiple injections for the next couple of years, it is cheaper to have the surgical intervention and a better quality of life than multiple coming every 3 months or every 6 months for multiple injections.
Yeah. Wow, so that's real interesting. But look, I know you have a special interest in some nice fancy surgeries that we could do. Gonna take a break right now, and we're gonna come right back. Just stick with us, and we'll bring back some nice information for you on surgical treatments for prostate disease. Stay tuned.
Medical Associates Hospital is the most affordable MRI imaging center in Trinidad and Tobago. Patients have quick access to bookings and service, on-time appointments, high quality, convenient, and fast scans with $800 off all MRI scans, we guarantee we have the most affordable MRI service in Trinidad and Tobago. Medical Associates Hospital, #1 healthcare for the entire family.
So welcome back to the Medical Associates Health Check, and we are about to get into the surgery side of things. Dr. Ramkisoon, I know you are involved in some laser prostate surgery and laser stone surgery, and you're doing some really fancy work. So tell us about these kinds of things that you're doing.
Right. So for gentlemen who have enlarged prostates, all right, I offer the gold standard, which is on par with international care within the top hospitals in the US, which is a holmium laser enucleation of the prostate, simply called a whole-up operation.
That's a real fancy word. Break it down now, please.
All right. So what it means, let's imagine the prostate is a Portugal. All right. The skin of the Portugal, the green, is the skin of the prostatic capsule. So the meat of the Portugal, that's the fruit, is actually the problem. So compared to other types of surgery, the whole-up operation is where you go through the urethra, so there are no cuts. And using the laser, I get into the right plane, which is simply the plane between the skin of the Portugal and the Portugal itself. And I use the laser and I separate out the entire inside of the Portugal, which will be the prostate, and then I suck it back out. So theoretically speaking, the operation takes me from anywhere from 30 minutes to 60 minutes. All right. After that operation, you will be on the ward for a couple hours, and then you go home the same day.
Wait. So those are the operations that when I come in the morning, I see you going in, and then in the evening when I do a bed check, the patient's gone home?
Correct. Yep.
Wow. That's
So
not bad.
we have pioneered in Medical Associates, have pioneered same-day prostatic whole-up surgeries. So this is even better than on par with international standards.
That's interesting. How many have you done?
I have the largest series in the whole Caribbean. I have about 330 whole-ups under my
Wow.
belt. All right. A lot of men, when they get referred and they come to have this laser surgery, they all ask, do I have to spend the night? And when I tell them, no, you're going home within 6 to 7 hours after the operation, they jump for joy and they're like, okay, let's do it tomorrow.
Right.
So some questions that are normally asked about the operation, which you may hear a lot of people talk about, does it affect your erections? Yes, in a positive way. You
That's
don't
always good.
lose your erections. In fact, one of my patients who had a 250-gram prostate, after I did his whole-up, he reports his erections are even stronger because big prostates tend to stretch the nerve and push everything to the side. So when you remove that, everything shrinks back down to what it should be. So you're going to get better flow within the nerves and better conductivity. In addition, a lot of men ask about continence. Continence after the operation. Incontinence, sorry, leaking urine. And I could tell you from my data, which is audited data, 91% of my patients are completely continent when the catheter is removed. And the remaining 9% get continent within the next few days. So at the end of 1 to 2 months, everybody, there's no leaking. You could go and run around the savannah. You could walk around the mall. There's no urine dropping out. In fact, because this is same-day surgery, a lot of patients come, they have their operation, and then they may fly back out of Trinidad or go back to work the next day. And everybody asking them, but didn't you do surgery? Where's the cut? And there's no cut.
Right.
There's nothing to show that you had surgery besides the prostatic tissue that I will show you pictures and videos of.
But since you're so skilled with laser surgery, is there any patient profile that you might say laser might not work for?
So
Might.
in 99% of cases, gentlemen who have enlarged prostates, laser is the way.
Right.
Okay.
A whole-up is your option. There are other types of laser treatment, but whole-up has stood the test of time, and whole-up is the gold standard.
Right.
So let me ask you this. You have this what sounds like a perfect operation. Are there any complications?
As with any surgical procedure, you could have complications.
So
you could
what-
have some bleeding after the operation, but like I show all my patients, and I guarantee them this, after you finish your operation, your urine is crystal clear. In fact, everyone lies down on the bed and they watch their urine coming out of the catheter, and it looks like water. We could probably sell it, How,
I don't recommend that.
But after the operation, when I take out the catheter, You're going to be passing your urine. You may see some little streaks of pale red, light red blood, pink Moscato, and within 2 to 3 days, your urine goes completely back to amber.
I have never heard anyone describe anything
Pink Moscato.
as pink Moscato. Far less urine stained with blood. I'll never be able to drink that again.
I'm sure you would.
Yeah. So Doc, I mean, you know, when we think of men and their management of prostate disease, it's not just a surgical condition, but it's something that affects them psychologically, you know. And I always ask surgeons these questions because I like to know that, you know, you all take care of the patient holistically, right? How you all manage or navigate this care for this patient in terms of bringing them back to the center of their care and, you know, handling other aspects of care, be it psychological help or managing their disease and, you know, managing their family expectations and stuff like that.
Well, one of the most important things is talking. You have to spend time and talk to your patient, hear their needs, hear their wants, hear their problems. And the moment you hear their needs, their wants, their problem, their issues, answer each one. Never skirt a topic. Be very detailed. Give them all the information. And don't show them what a way does. Show them what you do. So every single one of my patients knows my laptop. They know all the videos. They see exactly everything. So when you show a patient everything that you do and how you do it, they get confidence in you. And they say, hey, this guy knows what he's doing. Secondly, when you talk to the family, keep the family abreast with everything. Tell them what to expect before the procedure, during the procedure, and after the surgery. And keep a good follow-up of your patients. This quells all their anxiety, and it makes the pathway and the experience a one they will never forget, because a lot of patients have told me they didn't know surgery was so much fun.
Fun, you say?
Yeah.
Since you bring up that point of what to expect before, what they should do before, what might be some of the things gentlemen could do before they have something like this done, like the whole up?
Well, preoperative preparations for this operation is, one, if you're diabetic over the age of 60 years old, we'll do an echo to make sure the heart is working good. Because what we do at medical, we practice safe surgery. If you come walking in, you're going to be walking out my operating theater. So make sure the heart is good. Make sure there's no infection, because remember, with the prostate, an enlarged prostate, it prevents the proper emptying of the bladder. Stagnant urine is like how mosquitoes grow in stagnant water. You could get a urinary tract infection. So make sure there's no infections. So treat all infections, all right? Make sure the heart is good. Have a proper size of the prostate. I normally do ultrasounds also inside the operating theater when the patient is asleep to further delineate and mark off the territory. And those are the general basic stuff before an operation.
Nice.
Thank you very much, but unfortunately that's all we have time for today. You have given us quite a bit of information, so I'm sure it's giving our patients a lot to think about. So thank you for coming,
Thank you for having me.
and we hope to see you again next time, and we'll have a new issue to discuss. As always, if you'd like to contact us via our social media pages to ask any questions or ask us to discuss a certain topic, we are more than willing to listen. So thank you for your time, and we'll see you again next time.